Hey everyone, my name is Megan Tarvis and my presentation is on cocaine in pregnancy. So cocaine, as we know, is a Schedule II drug. As you see in the left upper corner, it appears as that white substance powder. It can be snorted or injected into the body. And it was originally used for medical use, like a local anesthetic applied topically. And that has become more rare as rates are higher for potential drug abuse. So national epidemiology records show that I found the study, it was rural versus urban, and they found that urban areas in 2016 were actually higher because due to the lack of resources versus within the cities. So as you can see, cocaine is rather lower in 2016. However, the rural areas is still considered higher. And then for the state, I found for Rhode Island, I live in Rhode Island. They couldn't find any pregnancy rates, so I put in just general United States adults use cocaine in the past 2021, and the state of Rhode Island is rated number 7 out of that list at 2.31%. And then we'll talk about the risks for maternal risks, heart attack, high blood pressure, stroke, weight loss, risk for infections from injection areas, loss of smell from snorting, seizures, and respiratory failure. Risk during pregnancy, you can have a miscarriage less than 20 weeks, placental abruption, hemorrhage, preterm labor, maternal or fetal death. And fetus can experience risk because cocaine crosses that barrier into the placenta. So initially the fetus is getting amounts of cocaine, so they can face birth defects such as cleft lip, Down syndrome, heart defects, cardiovascular and neurological defects. They can be born prematurely. They can be born with a lower birth weight, experience vision, hearing loss, and then even cognitive behavioral disabilities that can affect their life throughout their life. And then the most common one that everyone knows when working in OB is NAS babies, so neonatal abstinence syndrome. So this is, again, the baby's receiving the cocaine and they, after birth, they're withdrawing from it because they're not receiving that anymore through the placenta. So these babies experience withdrawals, such as tremors, irritability, excessive crying, and the inability to sleep. Delivery outcomes I included with cocaine use from that study because I saw that cocaine had the highest poor associated outcomes in 2016. As you can see, preterm labor was the highest association, and placenta abruption was the second highest. Screening tools used for cocaine can be tested urine, blood, saliva, sweat, hair follicles. But urine tests are the most frequently used because they're non-invasive and they're cost-effective. They actually they do produce false negatives, which can be a poor resource for providers, basically from the lack of recent use. So if they were used in the beginning of the week, it's only stays consistent in the urine for 2 to 4 days, as well as 1 to 2 days in the bloodstream. So the most accurate would be self-reporting screening of the individual, which can give us a more accurate result. So screening tools I found not specific to cocaine use, but more substance abuse. The 5Ps screening tool for substance abuse in pregnancy. One question is asked based on each item. So peers, parents, partner, pregnancy, and past. I have a slide on the next show to show you the example questions. NIDA is another quick screening, can be used for drugs and alcohol. WIDUS is indirect screening, but can identify drug use in pregnancy. And then CRAFT is also identifies substance abuse using 6 different tool instruments items. This was from a study, and it shows the different screening as you can take a look. For example, the 5Ps questionnaires. One of the questions is, before you knew you were pregnant, how often did you drink? Well, that one's for alcohol, but the NIDA question is asking more about alcohol, substance abuse, as well as the craft. So I looked at a study and it showed they collected data for pregnant patients regarding alcohol and substance abuse. The 5Ps showed the most, and the NIDA showed the most reliable screening tools. But again, the sensitivity for the 5Ps was higher, but the specificity was lower, as well as the opposite for NIDA screening. So the study concluded that there's no evidence that screening tools have both high sensitivity and specificity. But these are the screening tools for self-reporting used. And then as you can see, I included this data. I found interesting the first, second, and third trimester. They found that the first trimester had the most drug use in, as you can see, 430. So over time during like the third, there's an initial decrease in the third trimester. So patient's presentation, subjective symptoms include feeling restlessness, agitated, anxious, paranoid, feeling euphoric, energetic, very alert when they ingest cocaine, a loss of appetite, and as well as smell. And then objective symptoms that the provider can observe is pinpoint pupils. That's a most common one. Tremors, anorexia, and repetitive actions such as picking the skin, and infection present. Differential diagnosis. So cocaine toxicity can look similar to other diagnoses. So it's important that patients tell the provider that they are using cocaine so they can be treated more effectively. Objective symptoms of toxicity can include hypertensive, altered mental status, seizures, hyperthermia, delirium, vomiting, elevated heart rate, elevated respirations, they're restless. Subjective, they can have a headache, they can feel paranoid, experience blurry vision, abdominal pain, shortness of breath, nausea. But differential diagnosis can include withdrawing from any substance abuse, acute psychosis, schizophrenia, hypoglycemia, intracranial hemorrhage, neuroleptic malignant syndrome, and anticholinergic toxicity, also a state of delirium, or even sepsis. As they experience many manifestations, it can be hard to tell whether it's cocaine or not. And for prenatal treatment, I found difficulty finding this. I think because cocaine numbers have significantly dropped since the 1990s, based on my research. But detoxing from cocaine during pregnancy can reduce the risk of complications for both mom and baby. Women who quit during pregnancy will be monitored for their withdrawals, so they will, because they are at risk for complications like dysrhythmias, a heart attack, seizures. They would be admitted for an inpatient detox program because they want to monitor those withdrawals and medicate if treated. Case managers there to offer housing services or any support groups. Prenatal care is often given since it probably wasn't given prior. And inpatient, outpatient rehabs are offered after the detox is complete to have effective treatment. As we know, cocaine crosses the placenta and enters the fetus body, so the central nervous system is disrupted in the fetus, as well as the blood flow to the brain will become decreased. So frequent monitoring of the fetus during pregnancy is crucial. And looking at legal implications, I looked at the ACOG site and they had a policy on substance abuse. And in 2018, 38 states distributed laws regards to identifying the fetus as a victim of substance abuse. However, ACOG promoted a policy to prevent threats of criminalization because it essentially prevents pregnant patients from even admitting they are using cocaine or seeking help or treatment because they have fear that they're going to get criminalized for using. So ACOG recommends that a positive screen test does not indicate child neglect or abuse because it interferes with the individual's autonomy. If the positive test is positive, I mean, if the test is positive, they have the autonomy to whether to seek help or not. They have to have informed consent prior to any drug screening because the patients have the right to refuse. ACOG promotes that provider patient relationship, promoting primary prevention, access to treatment centers, and discouraging any mandatory testing. And that is my presentation. Thank you for watching.